Hello there, my valued, treasured and highly esteemed viewers and listeners, and welcome back. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I would like to urge you to sit back and spare me part of your very precious time to share some tips with you. Welcome to part 17 of our Pharmacotherapy MCQ series. So in our first question, after 2 years of therapy with glatiramer acetate, 20 milligrams to be specific, a patient WZO has had one relapse with imbalance and worsening gait. An MRI of his brain reveals one new non-enhancing lesion, and an MRI of his cervical spine reveals two new enhancing lesions. Patient WZO wedded recently and considers starting a family in the next 1 to 2 years. Baseline laboratory studies show normal CBC and WBC, and a normal ECG and JCV antibody is positive. So my question to you is, which is the best to consider for patient WZO? Should the patient continue glatiramer acetate because the disease modifying therapy, which we call DMTs, can't completely eliminate new relapse or MRI lesions? Or should we switch this drug to natalizumab, or should we switch it to ocrelizumab, or should we change it to teriflunomide? I'll give you 10 seconds to choose the correct option from that list. So personally, I would settle for alternative C. I would swap glatiramer acetate to ocrelizumab because it is highly effective and the patient has had breakthrough disease on glatiramer acetate, which is moderately effective therapy. Now, given his JCV antibody status and the fact that safer, highly effective DMTs are available, I would avoid natalizumab. Teriflunomide has category X risk, and the need for accelerated elimination before the patient begins trying to conceive would make me advise against its use. So in my opinion, the correct answer here becomes C, ocrelizumab. In our second question, ZWW, a 69-year-old woman, presents to the clinic with advanced Parkinson's disease. She is being treated with carbidopa-levodopa 25/100, and she takes half a tablet 5 times daily and describes her therapy as effective. However, her on time is typically associated with dyskinesias, followed by intervals of off time in between the doses of carbidopa, levodopa. So my question to you is, what regimen modification would you recommend for ZWW's dyskinesia? Would you administer amantadine, entacapone, selegiline, or would you change it to carbidopa, levodopa, but the sustained release form? I'll give you 10 seconds to choose the best option from that list. Personally, I would administer amantadine in addition to our carbidopa, levodopa. And it's a fact that amantadine reduces levodopa induced dyskinesia. Now, if you opted for entacapone, it may make the dyskinesia worse because it inhibits the metabolism of levodopa, and selegiline isn't effective in treating dyskinesias. And changing to the sustained release form might help the patient with the off times, but it would not sort the issue or the problem of her dyskinesia. So amantadine would be our best bet and option in this particular challenging case. Let's move to the next question. JMN is a 56-year-old woman who presents to the clinic for a follow-up for her migraines. She has a history of stroke without residue of effects and depression, and she has migraines about 3 to 4 times every month, which she generally controls well with the Imigran, sumatriptan 100 milligrams alongside naproxen at a dose of 440 milligrams at onset, with also propranolol 40 milligrams once a day for prophylactic purposes. And she inquires about Aimovig, which she read about on the internet, and wonders whether it could cure, in quotes, her migraines because she's tired of them. My question to you is, how best would you respond to this patient's query? Would you tell her Erenumab has proven more effective than other preventative migraine medications such as propranolol? Or would you tell her Erenumab was only approved for patients with chronic migraine? Or would you tell her that Erenumab wasn't studied in patients with a history of cardiovascular disease, so its safety in these patients is unknown? Or would you tell her that since Aimovig was approved, other similar medications such as Ajovy and Emgality have been approved that may be superior or better to it? I'll give you 10 seconds to make the correct choice from that list of options. So let's move to the slide with the correct answer. I would settle for C. Now, patients with cardiovascular disease were excluded from the Erenumab clinical trials, and calcitonin gene-related peptide plays a role in cardiovascular processes, so the long-term effects of Erenumab in this population are still unknown to us. However, cardiovascular morbidities aren't included in the package insert as a precaution or a contraindication. And this is more of a clinical based recommendation until more long-term data are available, so be cautious. Irenalimab has only been studied against placebo, remember, and no head-to-head studies suggest it is better than the other preventatives. Irenalimab was studied in episodic and chronic migraine headaches. This approved for prevention of migraine headaches. And we know that no head-to-head trials as such have compared it with fremanezumab and galcanezumab, the two drugs I quoted earlier. So as things stand, I would settle for C and be cautious, especially in the patients with cardiovascular disease. Remember, this patient has had a stroke before. So let's move to the next question. Mrs. TTT is a 43-year-old woman with a history of migraine without aura, who informs you that she has about 2 to 3 migraines on a monthly basis. She comes to the clinic to inquire about medications to treat her migraines and reports previous trials of the following medications. She's tried before fixed dose combination of acetaminophen 250, aspirin 250, together with caffeine 65 milligrams, co-formulated together. She's tried ibuprofen 800 milligrams and naratriptan 2.5 milligrams, and she confirms these medications at the onset of her migraine pain. She confirms taking them at the onset of the pain, but reports that none has relieved her pain. So out of frustration, currently when she has migraines, she goes into a dark, quiet room and just sleeps it off. She reports no other medications, and she is requesting a generic type medication for economic purposes due to affordability issues relating to her high deductible insurance plan. She doesn't want to copay at all. So in your opinion, which treatment option would offer Madam TTT an affordable solution? Would it be naproxen 500 milligrams? Would it be frovatriptan 2.5 milligrams? Or would you settle for rizatriptan 10 milligrams? Or would you inject sumatriptan 6 milligrams? I'll give you 10 seconds to make the correct choice. Personally, I would settle for rizatriptan, which is readily available in cheap generic form. Given her history, it appears that OTC analgesics and NSAIDs and triptans with slower onset of action, such as naratriptan, haven't relieved her migraine at all. It is therefore unlikely that she'll obtain relief from an NSAID, naproxen. So A becomes wrong when both acetaminophen co-formulated with aspirin and caffeine and a trial of ibuprofen have been ineffective in the past. And frovatriptan has a slower onset of action, so like naratriptan, it would not be a good option. And an injectable triptan formulation would be a good option for her, but this would be a cost prohibitive solution to her problem. Therefore, rizatriptan, one of the oral triptans with a faster onset of action, is the most appropriate option for her migraines. I would settle for rizatriptan and switch her to that option. Let's move to the next question. Which of the following hepatitis C or HCV treatments would be the best for a 65-year-old African American female patient without cirrhosis with the HCV treatment genotype 3 who hasn't yet been treated for HCV? Remember, her genotype is 3. Would you put down Dolutegravir, co-administered with velpatasvir daily for 8 weeks, or would you settle for Elbasvir alongside Grazoprevir daily for 12 weeks, or would you settle for Sofosbuvir alongside velpatasvir daily for 8 weeks, or would you settle for ledipasvir alongside Sofosbuvir daily for 12 weeks? I'll give you 10 seconds to choose one of the directly acting antiviral drugs from that list of 4. So personally, I would settle for Dolutegravir alongside velpatasvir daily for 8 weeks. Now, this combination is approved for genotype 3, and the rest are inappropriate for her genotype. So let's move to the next. Patient FUT is a 52-year-old man with asthma and chronic back pain. He requires NSAID drugs for his pain relief from you, and he had an uncomplicated peptic ulcer 2 years ago because of self-medication with NSAIDs to sort his chronic back problem. So what treatment regimen would you recommend for the management of FUT's back pain? Would you put him on 15 milligrams of meloxicam taken once daily orally? Would you recommend 800 milligrams of ibuprofen taken every 8 hours after food? Or would you settle for a combination of diclofenac and misoprostol taken twice daily? Or would you settle for naproxen 500 milligrams and give that twice daily while cushioning his gut with a PPI, esomeprazole, taken at a dose of 40 milligrams once a day? I'll give you 10 seconds to make the correct choice. Personally, I would settle for option D. Naproxen is correct. He has a moderate GI risk because of previous uncomplicated ulcer, and he also has a low cardiovascular risk because of the lack of use of daily low aspirin, which is usually protective. And naproxen is acceptable in his case, but must be used in combination with either a PPI or misoprostol in patients with a moderate GI risk. Now, the first two NSAIDs, meloxicam and ibuprofen, should be avoided due to the history of a peptic ulcer, and C is wrong due to the wrong misoprostol ulcer prophylaxis dose. It would be an underdose to give it at a dose of 200 mics BD. Let's move to the next question. A 44-year-old man presents to the clinic for follow-up. He has he has received the prescription of ranitidine 150 milligrams taken orally twice daily with an antacid for breakthrough reflux symptoms for 4 good weeks. And today he claims that his symptoms still require antacids by mouth 3 to 4 days in a week, but he denies chest pain, melena, dysphagia, or vomiting. So my question to you is, what is the most appropriate management strategy for this patient's GERD? Is it, or would you recommend an endoscopic procedure to probe further the cause of his problem? Or would you continue ranitidine for another 4 weeks and reassess his condition? Or would you change the ranitidine to a PPI, esomeprazole, at a dose of 40 milligrams once daily orally? Or finally, would you change ranitidine to a drug in the same class, famotidine, at a dose of 40 milligrams orally once a day? I'll give you 10 seconds to choose the correct option from that list. Personally, I would switch him to a PPI, esomeprazole, at a dose of 40 milligrams once daily orally. Therapy for severe GERD includes the use of a PPI, and this patient has had symptoms daily that have been uncontrolled by an H2 receptor blocker or antagonist and PRN antacids. Now, an endoscopic procedure isn't recommended unless alarm symptoms are present. It doesn't seem to have any, in my opinion. Changing medication within the same class, one H2 receptor antagonist to another, wouldn't likely improve symptoms in this patient's case, and an H2 receptor blocker isn't as effective as a PPI at treating severe GERD like this patient's case. So I would quickly switch from an H2 receptor blocker to a PPI. So that makes esomeprazole the correct choice. Let's move to the next slide. Patient DBV, a 52-year-old woman, comes to you and tells you she has sharp epigastric pain that seems to worsen after meals, and she informs you her belly feels full all the time and she often belches even in public, which is rather embarrassing. She has partial relief with antacids, but her pain returns after about 120 minutes after each dose of antacids. She has only begun having symptoms every other day for the past 120 days. A urea breath test was done and it is positive for Helicobacter pylori, and she has had H. pylori treatment before, for which she remembers receiving clarithromycin as part of her kit, and she tells you she has no allergies. So my question to you is, which of the following would be the most appropriate treatment for this patient DBV this time round? I'll give you 10 seconds to make the correct choice. Would you choose a combination of amoxicillin 1 gram taken twice daily alongside clarithromycin at a dose of 500 taken twice daily alongside 40 milligrams of omeprazole once daily for 2 weeks? Or would you settle for a gram of amoxicillin twice a day, 500 milligrams of levofloxacin once a day, and 40 milligrams of omeprazole twice daily for 2 weeks? Or would you settle for a gram of amoxicillin twice daily, co-administered with 500 milligrams of levofloxacin once a day, alongside 100 milligrams of doxycycline once daily, together with 400 milligrams of metronidazole taken twice a day for a week? Or finally, would you settle for 525 milligrams of bismuth subsilicate alongside 400 milligrams of metronidazole taken 6 hourly, together with 500 milligrams of tetracycline taken 6 hourly, together with 40 milligrams of omeprazole taken once daily? I'll give you 10 seconds to choose one of the 4 options. So I would opt for alternative B and switch him to a combination of amoxicillin, levofloxacin, alongside the PPI or omeprazole. Now, in my opinion, it contains the appropriate components for H. pylori salvage therapy. Remember, treatment has failed before, and this is used for the correct duration, which is 2 weeks. So the options with 7 days appear too short to me. Answer A is unacceptable. She has already received clarithromycin in her kit before, so it shouldn't be used as repeat salvage treatment after treatment failure. And in my opinion, short durations of 5 to 7 days are insufficient in length, and I would recommend 10 to 7 days as appropriate durations of treatment, especially when you are doing salvage therapy of H. pylori. Let's move to the next slide. A 55-year-old male patient is referred for hepatitis C genotype 3 treatment with glucoprevir pibentrasvir. Currently, the patient is taking 20 milligrams of esomeprazole once daily, half an hour before meals, for management of GERD. And for the hypertension, the patient takes amlodipine 10 milligrams once daily. And being male, he experiences erectile dysfunction, for which he occasionally takes vardenafil at a dose of 40 milligrams. And he also has epilepsy or suffers from epilepsy, which he manages with carbamazepine at a dose of 400 milligrams of the SR twice daily. And he also seems to have hyperlipidemia, and he manages that with 40 milligrams of pravastatin taken at night. So my question to you is, which regimen modification listed below would you recommend for this patient today before you begin managing the hepatitis C? Would you change his PPI from esomeprazole to lansoprazole during the HCV treatment? Would you discontinue the statin, pravastatin during the HCV treatment because of a drug-drug interaction? Would you refer the patient to a neurology clinic for a potential change in his epilepsy regimen? Or finally, would you advise him to discontinue the erectile dysfunction drug, vardenafil, during his HCV treatment? I'll give you 10 seconds to make the correct choice from that list. Only send him back to the neurology clinic because there is a potential drug-drug interaction here that would affect his clinical outcomes. There is no benefit in changing one PPI to another, especially when they have equal strengths, like in the case of esomeprazole and lansoprazole. That would not change anything. This patient can safely receive the statin, pravastatin, with the combination of glecaprevir, pibrentasvir, and using a phosphodiesterase type 5 inhibitor PRN for his erectile dysfunction is acceptable with a combination of glecaprevir, pibrentasvir. There is no drug-drug interaction there. Now it comes to his epilepsy medication, carbamazepine to be specific, is a cytochrome P453A4 inducer. Therefore, it will reduce the concentrations of the HCV drugs, and this could lead to loss of efficacy of the regimen, and eventually you'd end up with virologic failure, and they are quite costly. But the HCV treatment would fail if you co-administered glecaprevir with pibrentasvir alongside carbamazepine. So the neurologist would have to decide and switch to a drug that does not induce CYP3A4. That would be my take. I would settle for C. Let's move to the next question. A 49-year-old man with a history of cirrhosis from alcoholic liver disease presents to the hepatology clinic. His endoscopy done 7 days ago revealed 4 large esophageal varices, and their sizes were around 5 mm in diameter. They're quite big. Which of the interventions listed below would be the best for this patient's varices? Would it be administering atenolol at a dose of 50 milligrams orally once a day, or metoprolol tartrate 25 milligrams orally twice daily, or would you settle for nadolol 80 milligrams orally once a day, or propranolol 20 milligrams taken twice daily orally? So I'll give you 10 seconds to choose the correct option from that list of 4 beta blockers. So I would be biased towards propranolol at a dose of 20 milligrams every 12 hours orally. And we know that non-selective beta blockers reduce cardiac output and reduce portal blood inflow. And this they do through beta blockade. Thus, they are considered first-line therapy for the primary prevention of variceal bleeds, such as in this patient's case. Now, he has large varices as visualized on his EGD. Thus, he warrants primary prophylaxis if his situation is to get any better. And we know that atenolol and metoprolol are selective beta blockers, and they aren't effective in such situations. Nadolol is non-selective, but the quoted dose is inappropriately high. You cannot start at 80. An appropriate starting dose, in my opinion, would be half that value, 40 milligrams daily, and that dose would be titrated upwards, up according to the heart rate and his ability to tolerate. Now, propranolol has given good results in the past, so I would be good to go with propranolol at a dose of 20 milligrams taken every 12 hours orally. Let's move to the next slide. A 43-year-old woman with hepatitis B presents to the hepatology clinic to establish care after relocating to a new city a month ago. She reports to you that she has been taking Lamivudine daily for the past 2 years, which controlled her disease with an undetectable viral load, but she has missed many doses in the past few months due to stressors of relocating and due to the fact that she ran out of medication. And when labs are done, the tests show an aspartate aminotransferase of 111 units per liter, an Alanine aminotransferase of 99. Then there is positive hepatitis B core antibody. There is positive hepatitis B surface antigen. There is negative hepatitis B surface antibody, and the copies are 3,500,000 per ml. So which of the regimens listed below would be the best for her treatment now? Which one would you opt for? I'll give you 10 seconds to choose from a list of adding Lamivudine or adding tenofovir or changing to adefovir or changing to entecavir. Give you 10 seconds to choose from one of them. In my opinion, adding tenofovir would be the best bet. The salvage therapy option for patients receiving Lamivudine includes adding either adefovir or tenofovir. You can also change to a combination, fixed dose combination of tenofovir co-formulated with emtricitabine. Now, adding Lamivudine would not offer viral protection, and changing to adefovir wouldn't be effective because of an increased risk of viral resistance. But adding it would be effective. It can't be used effectively as monotherapy. Now, changing to entecavir wouldn't be optimal due to increased risks of entecavir resistance. So my best bet from that list would be to add tenofovir to Lamivudine and continue treating with 2 antivirals. Let's move to the next question. A 34-year-old woman presents to the pharmacy for her HCV medication Sofosbuvir and velpatasvir, which she usually takes orally with 600 milligrams of Ribavirin twice daily for her Hep C virus treatment. Which is the most appropriate counseling point that you'd give to this lady regarding this treatment? If you are the clinical pharmacist at that pharmacy, would you advise her to crush both agents if she has challenges with swallowing them whole? Or would you use would you advise her to use 2 forms of contraception during the treatment and for 6 months after completion of her treatment? Or would you advise her that when taking twice daily Ribavirin, the doses should be spaced exactly 12 hours apart? Or would you advise the patient that the medication must be taken with food? I'll give you 10 seconds to choose the correct counseling points from the list of 4. So I would settle for B. I would advise this patient to use 2 forms of contraception during treatment and for half a year after completion of treatment. Now, patients should be advised or counseled on the importance of not conceiving at all during treatment and for 6 months or half a year, to be specific, after completion of any treatment with Ribavirin. It isn't advisable to crush Sofosbuvir velpatasvir because of lack of any pharmacokinetic data supporting this. And Ribavirin is available in liquid formulation if needed. And the half-life of this product, Ribavirin, is long, and hence you don't necessarily have to stick to the strict 12-hourly dosing schedule. Yeah, because of that long half-life. Then Sofosbuvir velpatasvir, in my opinion, can be taken with or without food. That appears in literature. So that makes points D, C, and A incorrect. So I would opt to advise this patient to avoid conceiving during treatment and for half a year, and after completion of treatment, through proper contraception using 2 separate methods. Let's move to the next question. A 64-year-old male patient presents to his primary physician for a routine wellness visit before traveling abroad. In the course of evaluation, the physician notices several tumors on the patient's body. He does tests and the reactive plasma reagent turns out positive. So it confirms his fears that the patient could be having syphilis or could have had syphilis that was not well treated. Now, which of the following pharmacotherapy regimens would be the most appropriate for this particular patient? Would you administer 2.4 mega units of benzathine penicillin G intramuscularly, start, and that is it? Or would you administer 2.4 mega units of benzathine penicillin G intramuscularly once weekly for 3 consecutive weeks? Or would you infuse aqueous crystalline penicillin G 4 mega units IV every 4 hours for 10 days? Or would you administer ceftriaxone 1 gram IM once daily for 8 to 10 days? I'll give you 10 seconds to make the correct choice from that list. I would treat this gentleman by administering 2.4 mega units of benzathine penicillin G intramuscularly once weekly for 3 consecutive weeks. This patient most likely has tertiary syphilis, as evidenced by the tumors on the skin. Now, since tertiary syphilis has more systemic involvement than primary or secondary forms of the same disease, a longer course of penicillin G benzathine is indicated, specifically 2.4 mega units IM once weekly for 3 weeks. Now, a single dose is treatment for either primary or secondary forms of syphilis. And ceftriaxone 1 gram IM once a day for 8 to 10 days can be used as an alternative agent in primary or secondary forms. So it would not be ideal for this particular patient of ours who has tertiary syphilis. So I would knock off alternatives D and A. Now, penicillin would be preferred for tertiary forms. And even if the patient was allergic, I would consider desensitizing before initiating treatment. Now, aqueous penicillin is used to treat neurosyphilis. So I would also knock off alternative C and settle for benzathine penicillin 2.4 mega units once weekly intramuscularly for 3 consecutive weeks. Let's move to the next slide. A 55-year-old man has recent diagnosis of HIV. His past medical history is significant for hypertension, dyslipidemia, type 2 diabetes, all of which he tells you are well controlled with his current medication. Now, the ID physician has prescribed Dolutegravir alongside tenofovir alafenamide and emtricitabine as initial therapy for this patient for his HIV infection. So my question to you is, which of the following adverse drug reactions would be most likely to occur in this patient? Would he experience insomnia, nephrotoxicity, rashes, or depression? I'll give you 10 seconds to choose the correct answer. In my opinion, insomnia is the correct answer, and it has been reported as a common adverse drug reaction among any combinations containing an NST. Now, nephrotoxicity would be unlikely in this particular case since we are not using TDF, tenofovir disoproxyl fumarate, which is the common culprit that causes nephrotoxicity. We are using tenofovir alafenamide, which is safer, doesn't cause any nephrotoxicity. Now, the rash would be unusual for this particular regimen that has an NST, and it is mostly commonly seen when abacavir is used, especially in patients who are HLA-B star 57 allele positive. And I don't see any abacavir in that combination, so I would not be worried about rashes. Now, depression is also unlikely when using an NST. It is commonly seen with combinations that have in their backbone the NNRTI, especially efavirenz, and I don't see that in the combination, so that would be the list of my worries. Let's move to the next slide. A 30-year-old African-American woman has a recent diagnosis of HIV after a routine screening. Her current viral load stands at 99,000 copies per ml, and her CD4 is pretty high at 700 cells per mm. Now, she is HLA-B star 57 allele positive, but all other lab parameters are within normal limits. The liver, the kidneys are fine. Her medical history is significant for depression, which she currently manages by taking Duloxetine. Now, my question to you is, which of the following would be the best option to initiate for her initial HAART? Would you use a combination of Dolutegravir, abacavir, Lamivudine? Would you initiate boosted Darunavir with a combination of emtricitabine and tenofovir alafenamide? Would you settle for efavirenz, tenofovir disoproxyl fumarate, and emtricitabine? Or would you settle for Dolutegravir plus co-formulated tenofovir, alafenamide, and emtricitabine. I'll give you 10 seconds to choose the correct option. Personally, I would shy away from the rest and settle for Dolutegravir plus co-formulated tenofovir, alafenamide, and emtricitabine. Now, the HIV treatment guidelines recommend initial therapy with an INSTI-based regimen for most HIV positive patients, indicating that Darunavir and efavirenz regimens aren't correct. So that makes C and B incorrect. Now, efavirenz is a poor choice in this particular patient because it could worsen her depression. Remember, we are told about depression among her conditions, and we are also told she's HLA-B star 5701 allele positive. So that option with abacavir, option A, though it's first line, would be contraindicated in her case. That leaves us with a combination of Dolutegravir, tenofovir, alafenamide, and emtricitabine as our best regimen. Let's move to the next question. Patient JMF, a 22-year-old white female university student who weighs 70 kilograms, began experiencing fever, muscle ache, and coughing 1 day ago, and presented to the university clinic for evaluation. Now, an influenza test result turned positive. The rapid test turned positive, and she has no other medical history and doesn't take any other medication, fairly healthy, and she strongly desires to recover quickly as soon as possible in order to revise thoroughly for her final exams, which is scheduled in 7 days from now. So my question to you is, which of the following is the best recommendation for the management of JMF today? Would you give her oseltamivir at a dose of 60 milligrams every 12 hours orally for 5 days? Or would you treat her with 200 milligrams of amantadine orally once daily for a week? Or would you give her Duloxetine 40 milligrams start orally? Or would you tell her she does not need medication and advise her to use lemon, honey, and ginger and manage her fevers with acetaminophen? So I'll give you 10 seconds to choose the correct option from that list. Settle for C. Now, amantadine is no longer recommended for influenza treatment. This lady seems to have influenza because of very high levels of resistance to influenza to amantadine. Oseltamivir would be a good choice, but we usually administer it at a dose of 75 and not 60 milligrams every 12 hours orally for treatment. So that dose would not be optimal. Now, she isn't at a high risk of complications from the flu, in my opinion. Therefore, symptomatic treatment would have been appropriate. However, she has requested for something to help her recover quickly in order to prepare for exams. So we would opt to treat her. So that makes D, B, and A wrong choices. Now, Duloxetine 40 milligrams orally start would be the most appropriate option for this particular student. Let's move to the next slide. So a 28-year-old male presents to his primary physician's clinic complaining of 12 days of sinus pain and pressure that isn't improving, and he states that his greenish nasal discharge hasn't gone away, and the pain and pressure still persists. His past medical history is significant for allergic rhinitis that is usually managed with nasal sprays of a corticosteroid. He claims he got hives as a child, as a small boy, when he was given oral penicillin to manage his acute otitis media. Now, my question to you is, which of the following is the best treatment recommendation that you'd offer him now, bearing in mind that he's allergic to penicillins? Would you administer azithromycin? Would you prescribe amoxicillin? Would you prescribe doxycycline? Or would you settle for moxifloxacin? I'll give you 10 seconds to choose the correct option. I would go for doxycycline. Now, this fellow is a candidate for antibiotics for his acute sinusitis because he has had moderate symptoms which haven't improved at all for the last 10 days. Doxycycline, in my opinion, is the best choice for uncomplicated acute bacterial rhinosinusitis in patients who are allergic to and Alanine penicillin. So therefore, amoxicillin would be risky for this particular patient. Now, moxifloxacin, although effective and useful in penicillin allergic patients, wouldn't be my first choice because it should be reserved for refractory or complicated forms of rhinosinusitis, bacterial rhinosinusitis to be specific. This is not refractory, neither is it very complicated. So I would not go for moxifloxacin 400 milligrams orally once a day. Now, this patient has a penicillin allergy, so therefore amoxicillin would not be good for two reasons. It has poor coverage, poor activity against Haemophilus influenza, that is also a common cause of bacterial rhinosinusitis, and the patient is allergic to it. Therefore, amoxicillin will not be my favorite choice. And with azithromycin, it has poor activity against the major pathogens in bacterial rhinosinusitis, such as Streptococcus pneumoniae, due to high levels of resistance. So I would not settle for azithromycin either. So I would prescribe doxycycline 100 milligrams twice daily for this gentleman. Let's move to the next slide. Patient KLO, an otherwise healthy 20-year-old woman, presents to the clinic with a chief complaint of sore throat and feeling hot and cold alternately. Now, she claims the sore throat began like 2 days ago and isn't improving at all. She's tried gargling salt without success. The physician orders a throat culture which returns positive for group A streptococcus. She has strep throat pharyngitis. The patient says she has a history of rash with penicillin. Now the physician asks you for your recommendation. So my question to you is, which of the following would be the best therapeutic suggestion to the physician for Lady KLO's treatment at this time? Would you settle for 500 milligrams of cephalexin taken every 6 hours orally for 10 days? Or would you insist on penicillin V 500 milligrams twice daily for 10 days? Or would you settle for azithromycin and administer 500 milligrams on day 1, then move to 250 milligrams once daily for the next 3 days? Or would you settle for 250 milligrams of cefuroxime taken twice daily for 10 days orally? I'll give you 10 seconds to choose the correct answer. So I would opt to treat this strep throat with 500 milligrams of cephalexin every 6 hours for a total duration of 10 days. Now, cephalexin offers effective therapy and is still safe in patients with a history of rash with penicillin, and it doesn't have an unnecessarily broad antibacterial spectrum of activity. So from an AMS point of view, this would be judicious use of an antibiotic. Now, penicillin VK would be incorrect because the patient has a history of previous allergy to penicillin. I would not opt for B. Now, azithromycin should be reserved for situations in which other preferred agents are not feasible. So I would not rush to it as my first choice. And then cefuroxime would be effective and provide an unnecessarily broad spectrum coverage for a relatively uncomplicated disease such as a strep pharyngitis that we have in this case. So I would not go for B, C, or D. I'll narrow my spectrum and settle for cephalexin 500 milligrams QID orally for 10 days. Let's move to the next slide. So a 13-year-old boy is brought to his pediatrician by his father, who describes a strange rash that looks like a bull's eye on the boy's forearm. Additionally, he describes a camping trip which the family took in the northeastern United States of America about 6 weeks ago, and the pediatrician diagnoses early Lyme disease, and the father states that the boy got hives when his otitis media was treated with amoxicillin, high-dose amoxicillin, when he was young, and they had to change treatment. So which of the following drug regimens would be the most appropriate for this boy's treatment now? Would you treat him with doxycycline, with oral cefuroxime axetil, with oral amoxicillin, or with clarithromycin? I'll give you 10 seconds to choose the correct answer. Because he is 13 years old, I would safely give him doxycycline in this case. It is the drug listed with the best evidence for effectiveness. Now, cefuroxime axetil would be effective, but not as effective as doxycycline. And in my opinion, he's old enough to safely receive doxycycline. Amoxicillin isn't an option. We have been told of a history of allergy to penicillin. And then clarithromycin doesn't have sufficient activity against Lyme disease, and it isn't listed as a choice treatment by guidelines out there. So I would pick A out of that list of 4 and knock off the rest. Let's move to the next question. A 19-year-old female presents to her physician with a complaint of painful urination. She describes a 12-hour history of dysuria, and the physician diagnoses cystitis. And this female informs the physician that she had a rash when she used cephalexin to treat a recent cellulitis, but she denies any nausea and vomiting when she took the same. So my question to you is, which of the following is the best empiric antibiotic therapy for this patient? Would it be ciprofloxacin, doxycycline, cefuroxime, or amoxicillin? I'll give you 10 seconds to make the correct choice. Choose to treat her with ciprofloxacin, and we know that doxycycline has some activity against urinary tract microbes, but I'll underline the word but. It isn't a reliable drug for such infections due to poor urinary concentrations. Treatment would fail in some cases. Now, cefuroxime isn't the best choice because she has a history of an apparent allergy to a cephalosporin. I would be very reluctant to treat her with another cephalosporin. Now, amoxicillin isn't appropriate because E. coli, which is a common uropathogen in such infections, has high levels or rates of resistance to amoxicillin, making it an ineffective choice in the management or treatment of cystitis. And that leaves us with ciprofloxacin as our best choice for the management of uncomplicated cystitis. Let's move to the next question. A 27-year-old woman presents to her physician with a chief complaint of diarrhea, and she tells you that she successfully completed a course of clindamycin for a dental infection 10 days ago, and she had complications after a root canal procedure. Now, she describes frequent loose stool around 7 to 10 times daily, and over time she has lost around 5 pounds of her weight since the diarrhea ensued about 48 hours ago. And she informs the physician that she has no fever and no chills, and she denies recent travel outside her hometown. She is slightly tachycardic, the heart rate is 76, and her other vitals are within normal range. So a stool test is done, and it turns positive for Clostridioides difficile toxin. So which of the following, in your opinion, is the next best course of action in her treatment? Would you treat her C. diff infection or diarrhea with metronidazole, with tinidazole, with vancomycin given orally, or with orofidaxomycin? I'll give you 10 seconds to choose the correct answer. So, basing on guidelines, I would opt for oral vancomycin 125 milligrams administered orally every 6 hours for 10 days. Although she doesn't have a severe case of C. diff, Vanco is considered the preferred antimicrobial for C. diff colitis. Metronidazole might have activity against C. diff, but it isn't the preferred choice compared to vancomycin as recommended by guidelines. And then, although tinidazole may be effective, there is no reason to expect it to be superior to metronidazole. And the last one, fidaxomycin, would be an effective choice, and it is a preferred agent just like oral vancomycin, but the cost is prohibitively high. So basing on cost benefits, I would opt for vancomycin, which would be effective in this particular case that is not complicated. So I would settle for answer C, oral vancomycin 125 milligrams administered every 6 hours for 10 days. Let's move to the next question. A 63-year-old patient receiving chronic hemodialysis is initiated on cinacalcet for secondary hyperparathyroidism. Now, which of the following, in your opinion, which of the following conditions listed below is the primary safety concern with this medication? Would it be hypocalcemia, hypophosphatemia, hyperphosphatemia, or hypoparathyroidism? I'll give you 10 seconds to choose the correct answer. Here, the challenge would be hypocalcemia. Now, calcimimetic agents such as this one significantly lower serum PTH. They also lower calcium and phosphorus in patients with end-stage renal disease. Now, hypocalcemia from these medications can be very extreme and life-threatening, and it can result in changes in ECG, it can result in seizures, it can result in muscle spasms, it can also cause myalgia and tetany. Now, although cinacalcet lowers phosphorus and PTH, these are unlikely to cause acute safety concerns, unlike hypocalcemia. So cinacalcet is associated with reduced phosphorus in the end-stage renal disease, so hyperphosphatemia would not occur. That would be the wrong answer. So because of that explanation, my biggest worry would be hypocalcemia, option A. Let's move to the next question. A 41-year-old African-American woman with type 2 diabetes mellitus presents to her endocrinologist for a routine follow-up appointment. Her serum creatinine is 1, and it has remained unchallenged for a year. Her estimated GFR using the CKD epi is approximated at around 82. And her urinary albumin to creatinine ratio, what we abbreviated as ACR, is 100 milligrams per gram, and a year ago it was 100. So which of the BP goals listed below would be ideal for her according to KDIGO, in your opinion? Would it be less than 120 systolic, 80 diastolic, less than 130 over 80, less than 140 over 90, or less than 150 over 90? I'll give you 10 seconds to choose the correct option. So personally, I would settle for 130 over 80. Now, the KDIGO clinical practice guidelines state that patients with level A2 or A3 albuminuria should have BP target of less than 130 systolic, 80 diastolic. Now, because her ACR is in the range of 30 to 300 milligrams per gram, she fits in the A2 category. A lower goal may increase risks of hypotension, so I would not go for A. So in my opinion, B is the correct answer. Let's move to the next slide. A 51-year-old man presented to an initial office visit with a new primary physician, at which he was given a diagnosis of chronic kidney disease, stage G3B, A2. Lisinopril 10 milligrams orally once a day was initiated, and he currently takes no other medication, and follow-up results 14 days after initiation of the lisinopril were as follows. So I'll give you 7 seconds to look at that table. So her serum creatinine has changed from 2 to 3.8 after 14 days of taking lisinopril. The eGFR has changed from 36 to 17, and the potassium levels have risen from 4.5 to 5.2. So my question to you is, which is the most appropriate course of action to take at this time to salvage his kidneys? Would you increase the lisinopril dose to 20 milligrams orally once a day? Would you continue with the same dose of 10 milligrams once daily? Or would you discontinue the lisinopril? Or would you add chlorothalidone 25 milligrams once daily orally to his treatment? I'll give you 10 seconds to choose the correct answer. Kidneys appear to be taking a hit. I would discontinue the S inhibitor. It appears to be harming this fellow. There is an increase in his serum creatinine and a decrease in his eGFR, and that merits the discontinuation of lisinopril. Although small increases of up to 30% in serum creatinine are expected after initiating S inhibitors, large increases, especially those over 50%, should warrant holding the medication and monitoring for the serum creatinine to return to baseline. Now, significant potassium increase also occurred in this patient's case, and that needs to be addressed urgently. You'd end up with very serious arrhythmias if it keeps rising, and increasing or continuing with the current lisinopril doses could only prolong or worsen the acute kidney injury and hyperkalemia. So I would shy off from continuing or increasing the lisinopril dose. I would opt for discontinuation, alternative C. Let's move to the next question. A 24-year-old patient approaches the pharmacy counter asking for a recommendation to treat his allergies, and he claims that he has had seasonal allergies in the past, but usually he has not been compelled to use any pharmacological treatment. They've been mild. He's managed them symptomatically. This year, his symptoms are more severe, and he seeks a product for relief. And he informs you that the most bothersome symptom is nasal congestion. Currently, he doesn't take any medication, neither does he have any underlying medical conditions. So my question to you is, which recommendation would you offer him in order to get best out of the treatment? Which one would offer him the most relief? Would it be 10 milligrams of loratadine taken orally once daily? Or would you advise him to administer 2 sprays of nasal mometasone, 100 micrograms, into each nostril once daily? Or would you advise him to administer 1 spray of saline nasal spray into each nostril twice daily? Or would you advise him to administer first generation antihistamine, diphenhydramine, at a dose of 50 milligrams once daily orally? I'll give you 10 seconds to make the correct choice. And in my opinion, mometasone spray would be the best bet. Intranasal corticosteroids are the most effective in the treatment of conditions such as this, allergic rhinitis to be specific. Now, non-sedating antihistamines like loratadine are considered first line. However, many guidelines state that they are ineffective for nasal congestion when they are used as monotherapy. So unless it's used with something else, it would not be my first choice. Saline nasal spray could be used as an adjunct or as adjunctive treatment, but it wouldn't be the most effective option. And the first generation antihistamines like diphenhydramine are used when other agents have failed or when the patient would do well with somnolence, when somnolence is desired to calm the patient down. So because of all that, I would settle for mometasone, 100 micrograms, administered as 2 sprays intranasally once daily. Let's move to the next question. A male patient has a 9-month history of nocturia, weak stream, urinary urgency and frequency, with a prostate size of 45 and an AU score of 21, according to the AU BPH guidelines. So with those facts, what is the most appropriate treatment to initiate in this gentleman's case? Would you use silodosin, dutasteride, or a combination of tadalafil and doxazosin, or a combination of tamsulosin and dutasteride? I'll give you 10 seconds to choose the best option. I would opt for a combination, a fixed dose combination of tamsulosin co-formulated with dutasteride, which is marketed as Duodat. Now, this patient has severe symptoms of BPH, which are affecting his quality of life. He also has a large prostate, which is greater than 40 grams. Therefore, an alpha blocker is important to provide quick relief of his symptoms and is expected to provide symptomatic benefit within like 1 to 2 weeks, to be specific. According to the MTOPS and the COMBAT trials, he would also benefit from concomitant administration of what we call the 5-ARI therapy, especially because of his large prostate. Now, combination therapy would be expected to slow the clinical progression of this BPH and would likely reduce the risk of acute urinary retention and BPH-related surgery compared with monotherapy with either silodosin or dutasteride alone. Now, tadalafil isn't recommended for use in combination with non-selective alpha blockers for the treatment of BPH because the risk of hypotension would be very high and such patients would be at risk of fall. So with all those facts, I would settle for alternative D. D would be my best choice. I would administer Duodat, a combination of tamsulosin and dutasteride. My highly treasured and highly esteemed viewers and listeners, that brings us to the end of part 17 of our series of Pharmacotherapy MCQs. Thank you for being there for me. If this video helps you in any way, I would like to urge you humbly to remember to give it a thumbs up, to like it, And I would also like to urge you to subscribe to my YouTube channel if you haven't already done so. And I would like to promise you that the best is yet to come. Thank you for viewing and for listening. I appreciate your partnership, and I hope to interact with you in part 18 of our Pharmacotherapy MCQs series. Thank you for being there for me.